The role of people like me is to, number one, inform diagnosis and treatment. It's a medical problem with psychiatric symptoms that show, and that's your tell, that's your mark of how you're progressing generally. So it's good to have someone who can, parts of it are obvious, but if it's helpful to have someone with expertise in mental health to help gauge the progress with your different treatments and the diagnosis. And we would try to support and educate the families. We need to try to help people keep their children and themselves safe. The children need to get important treatments and diagnostic procedures. So that's part of our job too. People who have never met someone with PANS, this is what I would say to them. The child is very ill, but they're not bad. But they may look like they're being bad, like they have bad behavior. People's relatives even say your child's just being bad. Well, they're very ill. Often the kids, as you know, probably, they can't function socially, academically. They can't do their usual fun things. They might need constant supervision. And most families are not set up for that once a child is school age. They can get all the way better. Rehabilitation in terms of brain rehab, if you had a stroke, you would the next day be in brain rehab. So children need it too. They have had an insult to their brain, and luckily, public school is right there, and that's part of the rehab, but it hasn't been tested. Kids with PANS and PANDAS don't respond to the usual psychiatric medicines as you might expect. So that's something that people with PANS experience in mental health need to understand. And most kids need some adjustments to their schooling. I don't need to tell you, unless some people are here are not PANS parents, it's extremely difficult, hugely difficult. The treatment path is unknown, right? We're working toward it. And I think we're making progress, but it's not a slam dunk clear course. Many professionals don't know about PANS, or if they've heard of it, they're not going to treat it. Once you're diagnosed, there are many, many appointments to different specialists. Often parents have to take time off work. The patient may be home from school, which if you're not used to having a child at home all day is very taxing. They can have cloying separation anxiety where you can't go to the bathroom or take a shower without the door open or the child in the room, back to having a baby in a carrier practically. People have lots of trouble sleeping, partly because the child is glued next to them and is restless and wet the bed. It's hard to manage behavior. We've had parents say it's very socially isolating, that their friends don't understand, their families might not even understand or might blame them. And you can't go stand in the carpool lane and say, oh, you're going to the soccer game. Are you going to the award ceremony? It's a very different change of life often, at least for that child. Other children, how could they get the attention they usually get? And I talked a little bit, they can get waiting and waiting. I think Melissa even mentioned PTSD. If you have a resolution, that's great. But parents often are in this state of suspense. When's the next flare? I showed you a questionnaire yesterday called the Caregiver Burden Inventory, and we've measured it in our parents. It's the best measure we have of disease severity. How do you know how the kid's doing? You ask the parent. How burdened are you? The kids' parents with PANS get a score that's higher than people caring for someone with Alzheimer's, which is a very difficult task. It's like people who have Rett syndrome, children, which is a kind of autistic disorder, And half of them should have qualified, if there's any kind of system that gives respite care, that they should get it. And flares were worse, not surprisingly. Happily, in our clinic, we saw a downward drift in the severity, so we hope that means we're being helpful. And the earlier the child got in to see us, or I think anybody else, we could generalize, the less burden on the parent. The treatments for psychiatric treatments for PANS, and I'll just say psychological, psychiatric, I'll just say psychiatric. The treatments are derived from the treatments that you'd give for anybody who had that particular problem, whether it's tics, OCD, food restriction, anything on this list, in addition to the medical treatments. And this slide is in here to say coordination of care and a big team is generally needed. EDO is eating disorder specialists, ENT is ear, nose, and throat. You need to have therapists, often occupational therapists, to deal with some of the motor problems. Physical therapists, because often the kids, as I showed you, have this poor muscle tone and weakness. Teachers and educational specialists. And parents are the ones that lead the whole game. They're the case managers, at least where I live. And I don't know if you all have an abundance of case managers, but it's going to fall on the parents. As you know, or as you've seen, you need to become as expert as possible, more than the doctors. And first be really upset that the doctors don't know, and then just practice radical acceptance and say, it's how it is. I mean, some doctors are quite expert. I'm not saying there aren't ones. But you might also encounter doctors that don't, and you just say, then I'm going to have to try to learn everything. And tactfully, hopefully effectively, help your child get the care that you believe they need. I said yesterday that going carefully through all the types of obsessions one can think of is the way to get a good handle on the diagnosis of OCD. This is a list of the obsessions I talked about yesterday. The compulsions is just like regular garden variety OCD, which who knows what garden variety is, right? Sometimes you don't know what the obsessions are, and you don't know what the compulsions are. If it's preying in one's head, you might not know. You've tried to get your child to be clean and neat, and to clean and neat, maybe, what's that? It could be a symptom of OCD if it's a change. Canceling, undoing, like surreptitious tapping, evening out. There's so many. It's worth looking at the scales and you could talk to your child about it and try to observe. The management is just like management of regular OCD. Cognitive behavior therapy, well, if your child's having rage attacks, it's probably not the moment to start exposure therapy. It could be in between. But it's really important for parents to learn, or therapists to help the parents learn how to do the CBT, what are the principles of CBT. And then as things get better, they can help with helping the child learn how to either resist doing the compulsions, because the more you resist doing the compulsions, the more you train the neurons in the brain to be able to go that direction versus this direction. Or in modern CBT, one of the principles is you can stand it. You can't extinguish all fears. I mean, you have to have some fears, right? You run out of the burning building. You're not going to extinguish that, and you shouldn't. And some OCD fears are very difficult. Like, what if it's about getting an infection that you only see 6 months or 6 years later? You can't really extinguish that easily. But can they stand the anxiety? That's a modern wave of CBT. What do you think it would be like when you try this, or don't do that, and then you have them do it, and then how bad was it? And try to help them understand that it's bad, but it's not as bad. Like if this is how bad it was, you start here and you think it's going to go here, but actually it went here. And that's another kind of learning that CBT can help with. In terms of medications, if your child has severe OCD with PANS, you're going to be likely trying antibiotics, immune therapies. If you start a psychiatric medicine at the same time, if they get better or worse, what was it? It's very hard to tease apart if it's even possible. And the most commonly used medicines and the appropriate medicines for OCD are serotonin reuptake inhibitors, SSRIs, selective. And our kids are prone to side effects that look like PANS symptoms often. Behavioral activation, suicidal thoughts, agitation. So I think they can be quite helpful. And when to start them is probably a little later than in a very acute flare. Treatment of food restriction is like any time you would treat medically, how you would treat food restriction from anorexia nervosa. Kids might need to go into the hospital. If it's a coordination of your throat, if you just think about how to swallow, what do you do first? What do you do second? It's an amazing coordination job, moving food around with your tongue and getting it down. So occupational therapy can help with that kind of thing, or with dealing with repulsion by certain textures. You might need a dietary consultation. Many of the kids are picky eaters already, and it can get worse when they're restricting food. And Dr. Sweeto has always recommended that if this is one of the issues, to get a swallowing study, meaning an X-ray study to watch what the process of swallowing looks like. Most kids have contamination fears. A lot of them have fear of vomiting or choking also. That's hard to treat, but it's you have to treat it. Focus on calories in. If you're treating this at home, doesn't matter what it is. Junk food, I don't care. Fry it and with cream on it. Whatever you can get the calories in at the moment. That's the important thing. That comes from family-based therapy for refeeding anorexia nervosa patients. But the principle of that is we're all sitting down, including the siblings, and we're going to do whatever it takes to help you eat. And maybe that's no one gets up till you've eaten. Parents know what an adequate meal is. If you need your friend over, the TV on, music, nose plugs, whatever it is, it's a life and death problem, and we are going to not leave your side. We're going to help you through this. And it obviously sounds coercive, and when it's life and death, it is. You don't let your child run in the street either. People might need to stay in the hospital if they've lost too much weight, if they're too dehydrated, if their blood electrolytes are off, or their heart rhythms are off, if fainting and have other medical problems. Moment-to-moment behavioral management. I just love this picture, so I always put this slide or something with that picture in it. Is it the moment? Is it the right moment to have real-life, normal expectations? For some things, yes. You have to eat and drink. You have to stop being violent. You can't hurt yourself or somebody else. Can you make someone go to sleep? No. Can you make them sleep alone? It's worth trying because you need sleep. But you might wake up with someone next to you. Can you just stop compulsions? It seems, if you don't understand or haven't seen OCD, it seems like just stop. Just stop. Why don't you just stop? It's so illogical you're doing that. But if people could, they would have. Can't make people stop crying. And it's hard to get to school, and that's a hard one because you would like life to be as normal as possible. Distraction is quite good. So I would think if you can get the child to school, do it, but sometimes it's not the right day. And sometimes people take their children out of school for this or that reason, and everyone's so individual. I want to talk about rage attacks. If you haven't seen them, it's like a sudden thunderstorm, but not even as much warning. Suddenly the child will become aggressive. Who is it? They don't bite, they don't kick. Where did they learn that language? It's shocking, actually, what you hear. And you don't know, I don't know where that came from. They didn't hear it before. It could be they see something as threatening, like we have to go to the doctor, we have to get in the car. You try to minimize things that could make it more likely, like hunger, thirst, pain. Kids don't often talk about their pain because there's so much else going on. It's good to find out about. Sensory overload, frustration, change in routine. And like OCD can play into this. We always go that route to school, but you went that way, or you moved some of the furniture. You might not guess that that would cause a rage attack, but it could. Sometimes with psychotic thinking. Nobody's home to talk to and reason to, in my experience, in our experience, when someone's in a rage attack. And you've seen pictures of it. There's not reasoning that can be happened. Could be the inflammatory cytokines are making it. There were some experiments they talked about in medical school where if you touch a certain part of your brain and excite it with chemicals or electrical stimulus, you just get this instinctive automatic rage that they would do it in cats and they just go, if you just touch that part of the brain. So I think there's a certain irritability. When this happens, take out like your geodes and other kind of things that might be harmful, right? Don't move the child. Don't try to manhandle the child unless it's a dangerous situation. I wouldn't go close to the child or touch them unless you've already learned that's something helpful. I would avoid sudden coming back at them. I think that will not help. Move yourself and other people kind of away, give them some space. If you think they're okay to be safe, if they're going to be safe, if they're left, not with someone restraining them or something, depends on your situation. Just wait for the child to calm down. Don't ask them to apologize. They're going to come and apologize to you most likely. I'm so sorry, I don't know what happened, I don't know why I did it. Don't punish it. That's not going to help anything. And if whatever you know about your child to help them calm down, I would pull that out. Call 911 if it is necessary. Distraction can be very helpful. Sometimes some medication can be helpful, but how do you get it into the child at that moment? Sometimes the children, like from experience, will know. Sometimes it can be helpful, but sometimes not. For example, benzodiazepines like clonazepam or lorazepam can calm someone down, but it also can make them seem kind of like a bad drunk. It can make them agitated. Try to help parents learn how to assess safety. And part of that's knowing your child. We have some new psychiatrists in our clinic, and they've just come out of training, and they have a lot of knowledge that I don't have, and I have knowledge that they don't have because I'm so much older. But if someone says, I want to kill myself, part of that is you have to obviously you take it seriously, but you have to understand, what does that mean in your child? What is your capacity to hold them? What's going to happen later? But in our experience, if you say you're going to, this threat's not quite saying, if you say, I'm going to call 911, I don't know what number you call, but Okay. They put me in room 911 at my hotel. I was like, I'm ready. It said, if you say you're going to call 911, then and never do it, never mean to do it, if you just like fake dial, you will lose credibility. It can be embarrassing in your neighborhood to have the police come, but children, probably anybody, does not feel comfortable when they're feeling out of control to know that their environment can't hold them, can't help them get it together. So follow through on that. In our experience, if you say, oh, my child has PANS or PANDAS to the paramedics or the police who come, it's like, what? But if you say they have a brain condition or inflammatory brain disorder, then I think they will understand kind of what they're dealing with, and it's not naughtiness. I had one person come in and trying to help with this, and they said, and clean your room. And that's what the policeman said. Well, I'm here. I just have to say. That was nice to have a little levity, but if you know that your patient's on the way to the emergency department, if you can have your doctor give a call to let them know who's coming in and what you think the problem is, I think that can be very helpful. I was so glad to hear and envious, frankly envious, that I heard that there are here hospitals with psychiatric wings, and that if you write orders, people will do what you hope, what you've ordered. We don't really have that, so I don't know if I should dwell on this. Where I live, psychiatric units have dried up because they don't make any money. And when the children go to a medical unit, they're used to sick kids who lie in their beds and do what they're asked to do. Well, if you have someone with sensory amplification, it's hard. The feeling of the cuff, the blood draws, the dings all night long of the machines next to your bed, all sorts of people. It can be really hard to hold it together. And it's hard to get for us to get medical admission criteria met. So where I live, often kids have to be managed at home. All these symptoms, this is just a list of symptoms, they can interfere with school. OCD, you can have rituals that interrupt your day. You might have to go wash your hands in the middle of class. You might not be able to play with clay, etc. If the teacher knows this, that would be very different than thinking they're just being obstreperous and not doing it. Separation anxiety can make it hard to get the child to school. Social anxiety and performance anxiety. We've had a child have school refusal because he didn't feel sharp, and he had been top of the class. Well, not just one, a number of them. And they just can't face, they don't want to face going back and not feeling smart anymore because they have slower reading and difficulty with math, for instance. They can be really fatigued, they can be really grumpy. They can be hurting. They can have trouble concentrating. They may need to go to the bathroom many times. You might need to get help for handwriting problems. If they can keyboard or have a proctor or have someone write down their assignments, maybe the parent at home helps with the handwriting part, but you have to kind of work with the school about this. Most children will miss some school. Most children do need some sort of accommodation, and generally schools have limited resources. Teachers have huge demands on their time, and usually we call it individual educational plan, individualized. It's usually written for a child who is pretty much steady state over the year, and you're hoping they're improving, but you don't generally write plans for people who sometimes need it and sometimes don't. Sometimes need it, sometimes don't. Hello? Is it working? Okay. I don't know how close to, is this all right? Okay. It's hard to write a plan for someone who sometimes needs a lot of help, sometimes needs to be excused, and sometimes there's a point, like if you've missed 2 weeks of school, then the accommodations kicked in. But what if they're ready to come back after 10 days? What if, I mean, it's very difficult when a moving target, and I feel for the schools. This is not how it's set up. But in any kind of interaction with the schools, the more specific you are in help. Oh, thank you. Yeah. Oh, okay. The more detail you give them, like, help my child, they have OCD. What? You know, help my child, they need to use their own pencils. Okay, they can get that. But really, there are myriad OCD symptoms that it's not helpful to just say, help with the OCD. We have learned kind of the hard way that we really need to interact with the schools closely. You know, we were writing these letters, this child needs these accommodations, school, do all this. And they're saying, wait, you don't know how the child is in school, you haven't talked to us. And this, lots of times, why would they know? Schools don't necessarily know about PANS and PANDAS. The better collaborative relationship you have, the better, and you can problem solve what accommodations are possible and what the child needs better. Eventually, I think it's important to get neuropsychiatric testing. That's this testing I've been saying is so scary, but it's extremely helpful to understand what are the child's strengths so you can play to them, and what are areas where it's very difficult for them to learn without some accommodations. Families need to be assertive and pleasant, but assertive. It's not a reportable problem like rheumatic fever, but you can ask them to please notify you if there's strep in the school. Hand washing education would be just normal. Twinkle, twinkle, little star type. That's how long to wash your hands. Dr. Pasternak will talk to you more, and he has, about prophylactic antibiotics. Kids sit with their heads together. They are working on projects on tables. I mean, they're going to share germs. So it's a decision one needs to make. Back to the medicine. We don't have studies about, in PANS children, how does fluoxetine work? We don't even have the other kind of treatment studies enough. So this is going to happen later. Plus, in what stage? It's really hard. In a flare, in recovery, I feel confident that you can use the regular psychiatric medicines in a regular way and get benefit. But as I said before, only a little bit to start out, and lots of check-ins, because if they need it now, when they're quite sick, for example, something that helps with aggression or anxiety, short-term, maybe they won't need it in 3 weeks. So it's important to check in frequently. And people who are in pain might act out in a way that looks like a mental health problem, but it's easier to treat the pain, right, first. I mean, it's more direct, straightforward to try to treat pain in general. And then you might not have to consider psychiatric medicine. Sometimes you need to get help for a procedure. This is a child getting an MRI. Benzodiazepines, as I said, could make you disinhibited and make you not be able to cooperate as much, but it really can be helpful for anxiety. We've seen a couple kids who got catatonic, and it's helpful for that. Can sometimes help with mania, psychosis, and sleep. But they can make you sleepy. If you're studying for a test that night, taking benzodiazepines, it might be hard to recall what you learned the next day when it's more out of your system. And of course, one can become dependent on them, and that's a choice one has to make. If that's the only thing that works, you're going to say, okay, then we'll taper it later. That's not a crime. It is a problem that one has to understand. We also have used these other medicines. Gabapentin can help sometimes with pain and anxiety. Benadryl is like benzodiazepines, is you can have a paradoxical reaction of activation, but we find it can be helpful for anxiety. Also, hydroxyzine sometimes helps with anxiety and appetite. Clonidine and guanfacine are medicines that are used for tics and ADHD, but they can cut down your sympathetic fight or flight response to a degree, so it could be helpful for generalized agitation and anxiety. Propranolol works somewhat similarly. And atypical antipsychotics, the newer generation, can be quite helpful and maybe necessary, but they come with a package of possible side effects, including big weight gain that is hard to get over. But if that's what you need, it's what you need. For procedures, we've had to consult with anesthesia sometimes. For example, if someone needs to be admitted for plasmapheresis and just couldn't cooperate. So that's an idea. A lot of the medicines that are used for kids with PANS can affect their EKG in the same way. And if they're piled one on another, you get more of a risk of them affecting your EKG, making you more at risk for getting an arrhythmia, an abnormal heartbeat. So citalopram, escitalopram, those are SSRIs. Mellaril, Haldol, Geodon, Seroquel are all antipsychotics that could be used. So one needs to check an EKG. Azithromycin, it's an antibiotic and an anti-inflammatory. It's a good medicine. It doesn't catch all the strep, but it's a good medicine. It also can prolong the QT interval. Zofran, when we have kids who get IVIG or we have kids on methotrexate, they can get really nauseated, but it's important to remember that can affect your QT interval, as can erythromycin or propofol, which the anesthesiologist would be the one using. These are not like the only books. These are my favorite books. And the other books I just haven't read, so that doesn't mean they're not better. But these are the ones in my office. I buy this Helping Your Anxious Child by the dozen, literally, for my students and classes. It's written by Australians for people to have a home treatment of anxiety, because it's hard to get in. I suppose it would be here too. You can print out anxiety treatment workbook, and so I use that a lot. I love What to Do When Your Brain Gets Stuck for little kids or big kids or adults, but it's written in the style for little kids about obsessive compulsive disorder. For parents, Talking Back to OCD is good, how to learn to not accommodate as much as possible. I had a patient where everyone had to strip clothes off going from the garage to the house as to not contaminate the house. And that once you start that, it's harder to fight than the first day saying no. That would be accommodating. There are 2 books here about schools and PANS. Sometimes you can buy them for the teachers or the counselor at school. Hair Pulling Habit and You helps you analyze. Sometimes kids get hair pulling, nail biting, skin picking with this trouble. It's a nice program to do an analysis of why, when, and how people pick and how to intervene with that and get rewards for not doing it. Managing Tourette Syndrome. There's a whole series called programs that work and treatments that work. And there often is a book for parents, a book for therapists. And I think they're well-written cookbooks, pretty much, of how to treat these problems. Managing Tourette syndrome, a lot of it is about habit reversal therapy, where you learn to notice when you're about to have a tic and try to do something that's opposite, with opposite muscles, to try to learn to not feed that it's like as though it were a compulsion. Not feed that loop like feeding the dog a biscuit. Every time it does it, it'll do it more. But if you don't give the biscuit, eventually it will stop begging for it. Here are some resources, and since you can get a copy of them, you don't have to write them down. Anything new here? I told you about the CME credit, and that's what I was hoping to say.